Morning, everyone. Good morning. You've heard we're recording, so please mute yourselves, except for the speaker. We're delighted this morning to have Silvia Pereira-Smith, who is an associate professor of pediatrics, Johnson University, Pennsylvania, and she's going to be talking about elopement in autistic children. This is a very timely topic. I was just up in New London, Connecticut, last week or so, and talking about safety issues in autism to the firemen. And I was saying one of the big ones is elopement, and I don't want to prefigure anything that Sylvia is going to say, so I won't give that particular part of my talk. But I was just saying that if you pay attention, you'll every month or so you'll hear about somebody in New York City, and within the last week, I think there have been two, a child and a young adult who have disappeared. So it's a very timely topic, and I'm going to shut myself up and turn things over to Sylvia. Welcome, and thank you very much.
Of course, thank you so much, Dr. Volkmar. And again, I'll mention in a little bit just how potentially life-threatening this can be, elopement behavior in autism. But as a developmental behavioral pediatrician, I see kiddos, and so my data will be focusing on children, age of 18. I was telling Eileen that I have some tech difficulties. And so sometimes things will go smoothly, but I keep it as low tech as possible. And so I have no financial disclosures, but I do like to share certain lenses that I see things from because, again, everyone comes with both implicit and explicit biases. And so just making them more aware of where I come from. I am a mother of three young kiddos. My oldest is neurodivergent, but not autistic. He is the one that is next door. With the strep throat. And so I told him he can play video games for this hour to leave mommy alone, but he might pop in. I apologize. I am also an active advocate for children with developmental behavioral disabilities and conditions. And so my goals for our time together this morning include explaining what elopement behavior is, identifying risk factors that increase an autistic child's risk of exhibiting elopement behavior, how to address elopement behavior by implementing elopement preventive measures, and understanding barriers associated with addressing elopement behavior. So, when I first started my work in this field almost a decade ago, and I mentioned the word elopement, both healthcare professionals and lay people expressed confusion since they associated that term with Vegas or a couple running off to get hitched. And it still occurs now, but to a much lesser extent, since thankfully there's been a lot of efforts to make everyone more aware of this potentially life-threatening condition. And so reports of missing autistic individuals are often present in all forms of media we access. And all but the last picture shown on this slide is just from the past month alone across the country. Some end in tragedy, and even those who have quote unquote happy endings must have still been really heart-wrenching for all of those involved, such as the child and the caregiver. One of the most well-known cases was Avante Okendo's disappearance in 2013, which led to Kevin and Avante's Law, which promotes initiatives that reduce the risk of injury or death related to wandering characteristics of some children with autism, but it's mostly been used to support funding of law enforcement on this topic. And so I can't talk about elopement behavior and autism without taking a moment to first touch upon autism spectrum disorder, which is currently present in 1 in 36 US children across all racial, ethnic, and socioeconomic groups. Elopement is defined as leaving an area without permission and placing themselves in a potentially dangerous situation. Families, to me, and sometimes in the literature, refer to other words such as wandering, bolting, or fleeing. In the literature, the term also used quite frequently, besides elopement, is wandering. That's the big heavy hitter there. And so, despite its severe implications, there's very few studies on this topic. And most of the studies on this topic are in the adult dementia population. The studies listed on this slide are from the past 12 years, and they found that one third to one half of autistic children had exhibited elopement behavior in the past 1 year period. The data from those studies was obtained solely from online or telephone surveys. The National Autism Association had published a study that examined over 800 missing person cases related to autism and elopement over a 5 year period, and almost a third of those were fatal or required medical attention. So that was almost a third, and over a third were classified as quote unquote close calls. More recently, researchers have looked into assessing the efficacy of elopement preventive measures. And at that point, no studies had assessed elopement in children whose families primarily speak another language besides English. And I still think that's the case. It's been maybe a month since I've last looked into the literature, so maybe something popped up in the last month, but to my knowledge, it has not. And so this article that I screenshotted here was from my research team and I that we published in April 2019 in a research journal called Autism Research. It's based on data we obtained from enrolling almost 400 participants from November 2016 to August 2017 at our developmental behavioral pediatrics subspecialty clinic at our academic institution here in Charleston, South Carolina, where I'm located, and we service the eastern third of South Carolina. And so this was the first study to assess lifetime elopement behavior rates in autistic children. We also sought to quantify caregiver use of elopement preventive measures for their autistic child, as well as identify variables that may be associated with elopement and with the use of elopement preventive measures to really help guide families, healthcare providers to be able to really support families regarding this condition. And in this study, we used both the caregiver completed questionnaire and we accessed electronic health records to review and be able to obtain accurate clinical information, including diagnoses and medications. So the questionnaire we used was created by myself with support for my co-authors and reviewed by a parent advocate group. Because elopement, again, was a word that many families had never heard of, and you can see in the screenshot right here, defined it as when a child leaves an area without permission can lead to potentially dangerous situation. And using the words that a lot of families tend to use when they speak to me in clinic, the wandering, bolting, taken off, and fleeing. And so we asked questions about the use of 12 different elopement preventative measures that were the ones recommended on most available online resources at that time. Since there, like I mentioned, very limited evidence about them beyond the dementia study, and our recommendations were really what were best practice for children at that time. And so the questions about elopement included categorizing the frequency of elopement as shown, I'm sorry, as described never, and then occasionally was 1 to 2 times, frequently was 3 to 5 times, and very frequently was over 5 episodes. We also asked the caregivers to select the child's sex, race, ethnicity, highest level of maternal education, primary language spoken at home, and we also asked about the child's communication ability. And so, like again, we mentioned, or like I mentioned before, we accessed the child's electronic health record to obtain the accurate collection of clinical details, like additional diagnoses and medications, but also insurance status. And we were able to translate all the study-related forms into Spanish. So that made it the first elopement study, and I think still currently the only elopement study to Spanish-speaking participants. And so 267 participants of the total 394 that we enrolled, or 68%, reported that their child had successfully eloped in their lifetime. 36% said that it happened once or twice. 20% said that it happened 3 to 5 times, and 12% said that it happened on over 5 occasions. And so, of the kiddos that were part of the study, 81% were male and 19% were female, which is kind of in line with the 4-to-1 ratio that we tend to see across autism research. 21% of the kiddos were preschool age, 54% were school age, and 25% were adolescents. 61% were non-Hispanic white, while 39% identified as other racial and ethnic categories. And this actually aligned with the US, not the US, I'm sorry, South Carolina census at that time. 97% of our participants primarily spoke English at home. And almost all, so I think, yeah, 91% of them had additional diagnoses besides autism. And what was interesting was that none of these social demographic characteristics or these things that I just listed actually were associated with elopement, increased elopement risk. And that's in line with prior studies at that time. And so, as you can see here, the maternal education. Um, for about half the mothers in our sample, they had a college education and insurance status. Slightly more than half of our children were covered by Medicaid only. And we do see a very high Medicaid population at my subspecialty academic clinic. And elopement risk was also not associated with any. And so I do apologize for the statsy nature of this slide. I actually toned it down a good amount from what I usually present at the research conferences. But the basic gist is that the only significant risk factor that we found in looking through all the different things increasing elopement risk was if the child was listed by their caregiver as having limited communication skills, which is that middle category there, defined as using pictures, using gestures, and or speaking simple sentences. And this is actually in line with a 2016 study done by Rice and colleagues that also found the same thing. We so nonverbal status was not associated with increased prevalence of elopement, which we had hypothesized it would be. And we found this interesting, but we speculated that maybe the caregivers of the children in this group might be extra vigilant because they perceive the threat level to be greater, that their child may not be able to communicate. And so they have to keep like a closer eye. So not included on this slide, but we didn't find that age correlated with elopement behavior either. Even though we hypothesized that it'd be more present in younger kiddos because, again, at ages 2 to 3, it is within the realm of normal development for children to elope. They're looking at their boundary or pushing boundaries, etc. So we thought maybe as you get older, you would have less elopement behavior. And we did not find that. And that is in line again with the other studies that had been done to that point, I think, since as well. Okay. And so in this slide, you can see that the use of the different elopement preventive measures that we asked about varied widely. In those who eloped, the most common EPM was locks at the top of the door at 51%, followed by ABA therapy at 45%, alarm system at 37%, and awareness of elopement by neighbors also at 37%. And less than a quarter of families were at that time, so current use at that time, having a disabled person's placard that you can see there is 23%, a visual sign or marker at 18%, medical alert bracelets at 15%, tracking devices at 11%, or service animals at 3%. And so that initial study that we did was not designed to elaborate on the effectiveness of each elopement preventive measure, but it did influence us to apply for a small institutional grant to help build escape kits to distribute to our families who were impacted by elopement behavior. And as you can see there, ESCAPE stands for Education and Safety for Children with Autism to Prevent Elopement. The original kits that we created in 2017 included a door window alarm, a child ID kit, stop sign visual aids, an ID bracelet, and some printed material that included additional recommendation for prevention tips. And so again, very bare bones, but we were able to get with our small pot of funding. And then in 2020, I applied for a Shark Tank type of competition that our institution has for innovative ideas to be able to support expansion of our escape kits and ideally be able to mail them out across the country to families of autistic children with elopement behavior. I did not win. I came in second place, but I was actually subsequently awarded enough funds to create 65 kits. And so as you can see in this picture here, this is what the expanded toolkit looked like. And that's my oldest, at the one that's next door with a strep throat. That's him at that age, showing them off. And so in this version, the escape kit items included, again, high locks or bolt for a door window alarm, reusable stop sign sticker, ID shoe tag with QR code, a wearable Bluetooth tracking device, safety harness, temporary tattoos, and then again, additional elopement behavior prevention tips information sheet. Because of the limited quantity of escape kits that we were able to create, my study team and I decided to proceed with a pilot study on which we would focus on young autistic children with elopement behavior. And while there are EPM kits available to families through different venues, this is the first one to be studied. We also wanted to look at or assess perceptions of kit item usefulness in targeting elopement behaviors. We wanted to learn which elopement preventive measures were still being used 3 months after kit reception. And we wanted to gauge caregiver perception of decrease in elopement behavior directly related to kit use and personal stress related to elopement behavior since receiving the kit. While the prior questionnaire that I mentioned before was on paper, this was only sent out electronically after caregivers chose to enroll if they saw a study flyer either through social media or at healthcare offices. And unfortunately, our limited funding did not allow for the online materials to be translated, which is really hard for me as a trilingual physician. I speak Spanish and Portuguese fluently. I have a lot of families that come to see me because of that. And so it really hurts me when I can't provide, or when I'm limited in my ability to provide the equitable access. And so, but we try to create what we could with the funding that we received. And so, through national social media advertisements, and sending flyers out to our community partners in South Carolina, in a 1 month period, we were able to enroll 65 caregivers of young autistic children who exhibited elopement behavior. So we looked at a lot of data in this study, but for time's sake, I want to focus on some big points. So we asked over the past year period, and again, this was in 2021, of the 65 caregivers across the country, 92% of them said that their children frequently or very frequently exhibited elopement behaviors. That's about 60 kiddos. And the overall rate of successful no elopement that the child had exhibited was 86%. So 56 kiddos had successfully eloped from their caregiver of those that enrolled in our study. And so hopefully the font's not too tiny for you all. I try to make it as big as possible because when I first created it, it was like tiny, tiny print. But as you can see in the chart here, caregiver ratings for perceived usefulness of each kit item depended on the particular EPM. So for the top rating of very useful, 71% of caregivers assign this rating to the high lock bolt on the door, followed by, excuse me, 62% with the door window alarm, about 57% for the recommendation sheet, 53% for the Bluetooth tracking device, 47% for the safety harness, 43% for the ID tag, 41% for the stop sign sticker, and then 36% to the temporary tattoo. In this slide, now you can see that the use of the different elopement preventive measures varied widely amongst the 58 caregivers that completed the 3 month follow-up survey. So 65 families received kits and 58 completed the whole follow-up survey 3 months later after receiving the kit. And so regarding overall use, over the 3 months of the different kit items, the most commonly reported was that high lock bolt on the door that we provided, and that was 88% of families were still or had used it, followed by the stop sign sticker, which was 86%, the door window alarm 83%, the information sheet 81%, the safety harness 66%, ID tag 64%, and the temporary tattoo 60%. And less than half of the participants had used the Bluetooth tracker during that 3 month period. We also wanted to know what items are still being used after 3 months. And so again, that high lock bolt on the door was still the most highly utilized, and that was 86%. And families were still using it 3 months later. And then the rates of the other kit items were as follows in decreasing order. So the door window alarm, 72%. The stop sign sticker is 69%, the safety harness 47%, the tip sheet 45%, the ID tag 36%, the Bluetooth tracker 26%, and then the temporary tattoos 22%. In 2023, I was awarded a research grant by the APA, or Academic Pediatric Association, to support another pilot study in which escape kits could be sent to families of autistic teens. And so, for the latest version of the escape kits, the EPM remained the same as the last study I just mentioned, but we were able to place them in boxes that contained a logo that our study team created for our kits specifically. And so the goals were similar to the last study, but we did want to compare the data between younger kids and teens. So the kids from this study and the kids from the last study. Our statistician hasn't gotten to that data yet, even though we've completed it. But I'm going to be able to share some additional information that we've learned thus far. And so 65 caregivers were recruited from October 2023 to February 2024. And the recruitment methods included, again, a nationwide social media campaign, tabling at autism-related events, and then distribution of study flyers to community partners and autism service providers. 49 of the parents or the caregivers completed a 3-month follow-up survey. So we sent out 65, 49 completed post-intervention stuff. And then of those 49, so different. The other percentages that we had mentioned, we asked in our baseline survey, and in this study, we asked it in our post-intervention survey. So of the 49 who completed those surveys, 51% had said that their kiddo had frequently or very frequently exhibited elopement behavior in the past 1 year period, and that their overall rate of successful elopement was 35%. And so this table, again, looks similar to the other one, but you'll see some changes in the perceived usefulness. And so the caregivers of autistic teens in here, the ratings for perceived usefulness of each kit item, the top rating went to the door window alarm. So 61% of caregivers assigned that rating to that specific EPM. And then was followed by 53% for the information sheet, 51% for that high lock bolt on the door, 47% to the ID tag, 43% to the Bluetooth tracking device, 39% to the temporary tattoos, 33% to the stop sign, and then 25% to the safety harness. And then in this slide, again, you can see that it varied amongst the 49 caregivers, looked a little bit different than the younger kiddos one. And so regarding overall use, so again, during that 3-month period that they had the kits, the most commonly reported to be used was door window alarm at 84%, followed by the information sheet at 82%, the high lock door at 76%, the stop sign visual aid at 63%, the ID tag at 55%, the temporary tattoo at 50%, the Bluetooth tracker at 41%, and the safety harness at 33%. Excuse me. Then one participant said they didn't use any of the kit items during that 3-month period. And then for kit items still being used 3 months after they received it, again, door window alarm was the highest, most utilized at that time, 80%, while the other were at follows. Let's see, the high locks was 63%, the tip sheet 59%, stop sign, visual aid 53%, the ID tag 39%, the Bluetooth tracker 33%, temporary tattoos 27%, and then the safety harness 22%. And then at this point, 2 participants were not using any kit items at the 3-month mark. So here you can see that we shipped our 130 escape kits across the country throughout our 2 pilot studies. The orange were locations where we only did it with the first study. The green is for the second study, and the purple is for states where we sent out both versions of the kit. Of note, we did have the ability to ship to any US state and territory. Excuse me. So what are the ways to address elopement behavior? The elopement preventive measures I'm about to discuss, again, are only some of the commonly recommended modifications. As I mentioned before, most of this is best practice because it has not been studied in pediatric populations, with the exception of ABA therapy, for which there are numerous studies, although they're still mostly case series. While children may still find ways to get to it and might eventually grow to the height of these locks, it's really about buying caregiver some time to intervene. And so that's, again, the reasoning behind recommending locks at the top of doors. Regarding the stop sign visual aids, many individuals with autism are visual learners. I am a visual learner as well, but that means we learn best through visual stimuli. And so it's interesting because families have shared with me in my clinic how often they're surprised by how effective the reusable stop signs are for their child. And the ones that we included and what we recommend for families are again reusable because um, we want to be able to maximize, again, thinking of things cost money. And again, if we buy a stop sign here and we buy a safety harness there, it all adds up. And so just trying to get things that are affordable and easy for our families. As for an alarm system, it can be a traditional system with the cameras and the chimes that are monitored by a company, or it can be as simple as, again, a two-sided alarm that beeps when the door or the window is open. And that's what we had included in our kit. Again, the point is to alert the family that the door or the window has been opened, and it might be the young child or the teen eloping. Medical alert bracelets are helpful for all types of conditions, regardless of age. And again, autism should be no exception. And so, even if someone is able to speak in full sentences, it can be hard to articulate when you're lost, possibly from fear or worry. And so, this can help alert others, make them aware that the individual might need some additional support, as opposed to incorrectly assuming that these behaviors are due to something else. Now, I remember when I was young and I had big opinions, even though I didn't know much, I thought I did. And I thought that safety harnesses were silly. But boy, since becoming a pediatrician, especially a mom, nothing is too silly to keep my kids safe. So I have two of these myself in the closets. And again, it might not be an option for all kiddos, as I think my pilot study for the teens is showing us alluding to. We still, like I said, have to calculate the data, but it's still something that I mentioned to my families, and there's a wide variety of it. I had a family that connected to the dog because it was a service animal and just kind of was able to stay with the child, and the child tolerated it better than if it was connected to the caregiver. And so tracking devices are the ones that I have caregivers often ask me about because I see various versions on the market, and I discuss with them the difference between what GPS covers and what Bluetooth covers. How GPS typically has monthly fees, which are often quite cost burdensome for our families. The Bluetooth tracker we included in our kits was a one-time fee, and it's paired with an app on the phone. And so it's not like a recurring cost. I didn't mention it, but definitely worth saying here that during our first pilot study for sure, the team, the creators of the Bluetooth tracker shared with us that they were having issues with the Android version of their apps. And so I wonder if that's why that was a 50%. I'm not 100% sure. I have to follow up with them if the most recent study overlapped with any app issues. I also talked to families about how some kiddos actually do better if the tracker's further away on their body from their line of sight, like their ankle instead of their wrist. Like I have a lot of kiddos that struggle with things around their hands, wrists, neck, but for some reason on their ankles, ignore it. And I do also tell them to check in with their local sheriff department to see if they have a program like Project Lifesaver, which allows for law enforcement to quickly locate individuals with cognitive conditions via GPS trackers in. Because again, wandering can be a life-threatening behavior across the spectrum of conditions and ages in which it is present. I mentioned before that applied behavioral analysis therapy has numerous case studies published in their journals, and it is important to know that there are criticisms related to ABA therapy. But for elopement, it's helpful to see it through the lens of the ABC method, or the antecedent behavior consequence model, as a way to understand and analyze elopement behavior in ABA. So, for example, if one notes that a child elopes because they were triggered by a loud sound, so that A, then we might consider using noise canceling headphones in public. So, altering the A to change the B. And then if a consequence, let's say, of elopement at school is to be sent home, then changing the consequence might change the behavior if the consequence is less desirable. And so I advocate also for my families to have the child's IEP reflect the elopement risk since it is impeding the child's education and that of peers at times. Even if a shadow or aid isn't feasible, like for most of my families here in the South Carolina public school systems, at least to have an updated functional behavioral assessment or FBA looking at the ABCs of the current elopement behavior, then having that subsequent behavior intervention plan or the BIP implemented to reflect that data, that can be really helpful too. This is a very good option for my families of children who bolt in parking lots, since parking closer to the entrance can be safer. I enter the order in our electronic medical system and complete the South Carolina DMV portions on paper that are applicable to me as a doctor. Then I give them to the families. But the doctor's order or the order in our medical system is available for only a maximum of 360 days. But this, again, allows us to have at least a yearly conversation on the variety of impact that elopement behavior has. I ask about elopement at every visit, but again, at least making sure like, is this something that we still need to do? Has the elopement improved? Because yes, these spots are closer to the entrances, but they're also bigger to accommodate those with mobility issues or equipment, and so judicious use. Um, this is a tricky one because, again, of a person's or family's right to privacy. And involvement with law enforcement can be tricky for historically marginalized groups. And so I do explain that with neighbors, they can be helpful since they might be the first person to see the child if they manage to leave the house. And law enforcement have resources available to find the child in a quicker manner. But at the end of the day, it is a family's right to share their information in a way they feel comfortable and safe. And then, as I mentioned, I'm a physician that specializes in autism and other neurodevelopmental conditions, but I'm also a parent, not of a child with autism, but my neurospicy oldest kiddo has and still exhibits elopement behavior. Um, and again, even though this is my lens, there might be some other parent perspectives that I'm not aware of that I haven't come across yet as a physician, as a mom, that might come across your minds through these next slides. And so maybe something we can talk about afterwards. And so I always say that the first step is to ask about elopement behavior. And from my personal experience as a subspecialist, many families initiate the conversation and they express their concerns regarding elopement because of how distressing it is for them and how much it endangers their child's life. However, there are also families that hesitate to mention elopement behavior because they feel it's a reflection of their parenting, with some admitting either current or past child protective service case involvement, cases that were opened against them because of the elopement incident. And that's actually what kind of got me into this line of work and all the stars aligned. But I had one family that shared, yeah, when I ask, I do at every visit, oh, was there any recent DSS cases? Yeah, our child we didn't know was tall enough to get to the door, but he did, and he went missing overnight. Cases closed and stuff. So it's not a judgment on parenting. It just sometimes, again, that Swiss cheese model, just everything lines up, and unfortunately, this happens. And then other families are less concerned about elopement because it's only like in specific settings, like at school, and they don't feel like they have as much say in that setting. But I say that even one occasion of elopement can have devastating consequences. And as an advocate for patients, I always say it's my responsibility as a developmental pediatrician to make sure that the kiddo is safe. And again, if I ask it at every visit, it normalizes the topic. Again, having resources to share with families can help promote confidence in discussing it. And again, there's some really useful websites and recommendations out there. So the first two links that I have on here share quick tips, and then the last one has extensive elopement resources. And again, that's one of the I think like the original toolkits available, the big red safety, which is awesome. And so again, as a professional, and if there are any other professionals on there on this talk, we can share again our knowledge with our families to empower them to keep their child as safe as possible. So I always hear the comment, "Oh, doc, I didn't realize that was an option that I could use to help address elopement behavior." But I really stress that elopement prevention is about adding on as many layers of protection as possible to buy the time needed to intervene, because there's really nothing that undoes it. Again, we mentioned a little bit about ABA, how it can change some ABCs, but everything is about adding layers of protection. And then you'll anyone that works with me or is in clinic with me will hear me say, I'm the expert in autism, ADHD, da da da, but you're the expert in your child. And so I give caregivers a space to talk about elopement behavior, share what EPM has worked or not worked for them, and then listen to the unique factors about their child, their home situation, their school setting that might help me suggest maybe some other EPMs that haven't been used yet and might be more successful. And so again, super important to come from a place of cultural humility. Because again, something that I think might be a good option might not jive with things that are important to the family. Like again, I mentioned before, right to privacy. So I don't want to push things. I just want to help brainstorm collaboratively. And I do highlight that if there was an EPM that didn't work before, it might have been because it just wasn't appropriate at that time. But it might be a better option now or in the future when circumstances change. Something that comes up, excuse me, a good amount for me is like families that they move and maybe they're renting and so they can't use like environmental locks that permanently impact the housing. But then I'm like, oh, maybe we can use some like removable double-sided sticky tape for the door window alarms. Like that might be a good option. So we kind of just tried to brainstorm together. And so I wanted to make sure that I open up time for questions and for conversation because, again, that's where I learn so much, especially when there's a variety of backgrounds, professional or life experience on our talks, et cetera. But I also did want to take some time to really share gratitude. So thank you to Dr. Volkmar for the opportunity to speak to you all today. I also wanted to thank my amazing research team at MUSC DevPeds. During one of those studies, I was on maternity leave for the my second kiddo, and they really kept things going. And so, I mean, they're awesome. I love my team. And then I also wanted to thank the funders for all versions, but specifically here is the information for the expanded Escape Kit funders. Oh, I lied. I had said that I didn't have any audio. Excuse me. That is my oldest one again, the one that's next door, the strep throat, running for me. And in this one, he was distracted by the pond, and we were safe. There were no cars around, but we were recently at Disney, and I definitely had quite a scare. And so I'll just, I guess, end the slideshow so I can see everyone's face. Okay, good. Did I do that okay, Eileen?
Yes, you did
Okay.
great.
I didn't end the meeting. Okay.
No, 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 you did. You just ended the slideshow.
Okay.
So I'm looking at the chat, and we do have a couple questions. The first one came in. It says, "What can we do at schools to meet the needs of our students and keep them safe? We are in Canada."
So that's a really great question because it doesn't even differ by country. It doesn't even differ by state. At least in South Carolina, it differs by county. And so I have again accumulated a lot of knowledge in my time. I guess I've been in South Carolina for 10 years and knowing what certain counties cannot provide. And so I think it's really getting just everyone at the table that you can. So having parent perspective, school psychologists, therapists, like who and the teachers, like whoever you can, and the child too, if they are of an age to be able to contribute and try to problem solve. So what I've seen successful is again, if someone could do a functional behavioral assessment to gather data, like how often is this behavior occurring? What is happening beforehand and what is happening afterwards. So, for example, every time we have a fire drill, Johnny escapes. Well, maybe it's the sound and maybe we can give him some warning. And so I think that has been the most successful in what I've seen. And I mean, I know that shadow and aid can be really, really, really helpful. I probably have a handful of kiddos of the thousands that I've seen, followed, et cetera, that have been able to successfully get them in South Carolina. Our resources are very limited. Again, when you come down to taxes fund schools and services. And when taxes are low, they don't fund those things. And so we are quite limited here in South Carolina. So it's hard. I do letters of support that again don't have to be followed. It is up to the discretion of the school, and I specifically use that sign. But I say, from my expertise, I support the family in requesting an updated FBA with bib for elopement. Um, I request a shadow aid, excuse me, for elopement, and again, just kind of giving the family support. But if there's anyone else on here that's had anything work for them in the schools, that'd be awesome because that's what we can get in South Carolina.
So the next question is, they would love to hear about family conversations regarding elopement in the car, such as out of a car seat to try or trying to open the car door during travel. What are others' experience with special car seat harnesses? Are there suggestions folks have?
That is such a tricky one, for sure, because car seats are just, I mean, just thinking of the sensory. So my middle child is not neurodivergent, and he's probably my hardest one to get in the car seat. And it bothers him and things like that. And so that right there is already, I think, exacerbating some of it. And so it's really, really tough. And this is sometimes we're having, again, some help if there is like a safety harness that we can attach to provide that extra layer in case like managing to escape. And this is where my disabled person's placard, it can be really helpful, especially again, some of the spots have that extra room to be able to accommodate wheelchairs, adaptive strollers, et cetera. And so having the stroller there is something that I've seen work for families. But it is just trying to get everything to line up. But it is so difficult. And so sometimes, if my kiddos are in ABA therapy, or sometimes with their occupational therapists, do, excuse me, some desensitization to the car seat issues that are pushing their sensory boundaries can be helpful too. I know I have kids that they get out of their car seats, and so having like those special adapter, like I don't want to say locks, etc. But some families have mentioned that has been helpful too. And so I hope that was able to answer the question. Again, if anyone on here has any tips that have worked for them or families or whatnot.
Couple more questions. Has research shown what pathophysiology that differs causing this urge to run? Sorry, I
No,
can't
no,
read.
no. The reason I'm smiling is because that is where I wanted to start off my research. I wanted to study that. That had never been studied before. And then when I did a deep dive into the literature, I found out that it was a pond where like I was like, I'm in the shallow end. There was no research. I mean, there was the original Rice study. I'm sorry, Anderson study from 2012, and then like two more studies on elopement. And I was like, I can't even study pathophys if we just have like one prevalence study. Like I had to scale back these grand research ideas all the way back to be able to figure out. And so that is my eventual goal is to get there. There is no literature there because of how little literature there is in this. And so even with funding, it's been hard for me to find it because it doesn't align with what a lot of the funding sources out there are interested regarding autism research. And so look, they kind of line up more with that, like pathophys and brain stuff. But I'm like, we're not there yet. We have all these like stepping stones we need to do before then. So my next line of research, if I could find a great funder for it, is to actually be able to build profiles. So kind of getting there, seeing if there's specific factors that lead to someone being more of a bolter, more of a wanderer, those kind of things. So the long answer to your question is no, I hope so. And I'm trying to do some initial research to get to that point, but that is my end goal.
Thanks. Next question. This person is actually in Greenville, South Carolina,
Hello, neighbor.
and they recently, unfortunately, had a child die from drowning after eloping from a classroom. We've been asking schools to come up with an immediate school area threat assessment plan for elopement. Do you have experience with this? And clarifying that we want them to assess water nearby, chain link fences, major roads, and having a plan with local first responders.
I That is so devastating. And I'm every time I see it pop up on the media that I access, I'm always like, oh my gosh, please don't be like one of mine and things like that. But any kiddo that loses their life or any adult, because I know Dr. Volkmar, you had mentioned in New York City there was the recent case of the adult because there's a lot of that as well. Just one life is too many, and the schools can do so much more. But you being in South Carolina know how hard it is. I'm originally from New Jersey, and maybe there's people on here from New Jersey who be like, ah, that's not quite the experience that I'm having. But like when I go home and I talk to my friends, or even I talk to my nail tech and I see the supports that their schools provide their kiddos, regardless of diagnoses, I am just super jealous. And I think the schools can do a lot more. You hit the nail on the head on getting law enforcement support because, again, they just have already resources built into place. There's the Kevin and Avante law with like funding that can be accessed typically through the law enforcement way. So much more. And I mean, I would be glad to talk to, again, not just Greenville, but anyone, share any of this information because it's really important. And kids spend so much of their lives at school. And so, yeah, it's really interesting. And that's also kind of just a little side note. You might have noticed it took us a lot longer to enroll the teens than the kids. And yeah, it might be related, like teens don't elope as much, even though my original research showed that that's not the case. Another research has showed it. My original or the first pilot study for the young kiddos was in the summertime. So less structure, a lot more water activities, especially in states that are a little bit colder. And so I wonder if like people were like, oh, I'm experiencing a lot of elopement now and maybe not so much temporally. But the schools can do, like I mentioned, so much. FBAs, BIPs, shadows if possible, though I know they're quite limited. Anyone else have anything? Again, feel free to hop on the chat and or unmute if any of there's any recommendations that you have for any of the questions being asked as well.
We did have a tip come through from Gary,
Ooh,
just saying with parent permission, include the school custodian in safety plans. Good eyes in the halls and doors.
agreed. I mean, they have such expertise and just behind the scenes knowledge. I love that tip. And that's why I'm a big fan of having as many voices at the table as possible because there's so many perspectives that we're not aware of. And that's such an amazing one. Thank you.
If I could just add to that, everybody in the school nurse, the lady sitting at the front desk, everybody should kind of know to be on the lookout. And I was going to add, the whole question of looking at typologies of bolting. I sadly have seen a lot over my career, and I've had kids jump in front of trains.
Mhm.
I've had kids open doors on the middle of Interstate 95 and hop out. And there's an excited bolting and jumping, and there's an escape bolting and jumping in terms of not wanting to be confined. I mean, there's all kinds of ways you could think about approaching this problem. One of the most interesting solutions I've ever seen from a parent point of view was some years ago now. A family had a child. They lived in a fairly large bit of land with a lot of woods. And so it was a bad place in terms of the good in terms of not getting run over, but bad in terms of getting lost. And they had this extremely well-trained, I think it was a Bernese Mountain Dog. It
Mhm.
was the biggest dog you ever saw in your life. It was the size of a small horse. And it and the child were chained together, the collar to the child's arm. When the child started to go off like that, the dog sat.
Mhm.
And it was so well trained when the child started to do this, the dog would come over and nuzzle the child to be petted. And but that's an extremely expensive proposition. In this case, there had been fundraising effort to get this dog for this child, but it can be such a problem. And as you say, we need more research to look at risk factors. And the big one you found, which is the one that I'm aware of, is the limited communication skills, the inability to say, I want out of here.
Yeah.
And so the child does it behaviorally instead. And then we need to understand what that's all about. But this has been a really fascinating talk. Is it okay if people email you if they have questions or thoughts?
Yeah, absolutely. I can put my email in the chat.
Well, that'd
There.
be great. Thank you. So I suspect this is a fairly large group for us. There'll be people who have either observations or thoughts. This has been a wonderful talk, and this is a very important problem. As I say, in the last week, I'm aware of both a child and an adult in New York City. So, and I always tell people when I talk about this, when I talk to parents, I say one thing you should do is have your child learn to swim.
Yes.
You
Yes.
know, whatever else is true, because that's drowning is the most common cause of death.
Yes.
Pediatricians will say to me, oh, yeah, but that's the most common cause of death anyway. And I say, yes, but it's double in autism.
Exactly.
So anyway, so thank you very much. This is a great talk. Thanks everyone for being on this morning. We really appreciate it. And we really appreciate this talk. It's been very good.
Thank you. Oh, I didn't hit send. There we go.
Oh, there you go. Okay, you
Did
got
it
it?
go? Oh, you know why? I know why. I send it to meeting room participants. There we go. Meeting group chat. I was like, wait a second, it's not hitting send.
Okay, so people should get it. So thank you very much, everybody, for coming. A great talk. And I'll see everybody next month. Thank you, guys.
Thank you, everyone.
For those that haven't registered, next month is listening in noisy and distracting acoustic environments for autistic adults. It's on December 13th. We have some space left. Please go in and register for that one too.